Welcome, everybody. Good to see you all. We'll just wait a couple of minutes for people to start coming in into the webinar here. Thanks for joining early.
Thank you. Glad to be here.
Glad to see you, Marlon. Yeah, I feel like I should have that on a loop. You know, I should just keep going. Welcome, everybody, because people coming in, and we should have that on a loop or something. Anyway, I'll keep talking so people know that we are live and well. Great to see people coming in. We'll get going in just a minute.
No problem, no problems.
All right. Well, we're at 12:02. That's usually our time to get started. And officially, welcome everybody to the Next in the Recovery Science Series, sponsored by the Recovery Research Institute and the Opioid Response Network through SAMHSA funding. Delighted that you're all here. Welcome back. If you're coming back, welcome. If you're new, delighted to have you. I'm Dr. John Kelly. I'm the director of the Recovery Research Institute at Massachusetts General Hospital. Delighted to once again have this great talk today, courtesy of Dr. Lauren Hoffman. To begin, we will just start with a brief video which introduces aspects of the Opioid Response Network and what it's about. So take it away, Maya. This is just a couple of minutes.
Communities across the nation are mobilizing to address opioid and stimulant use and the overdose crisis. You can't overcome this alone, but we can, together, and we are. We are the Opioid Response Network, a coalition of 40 national organizations representing more than 2 million people. We serve all 50 states and 9 territories locally through our network of nearly 1,000 professionals working across prevention, treatment, and recovery. For state agencies, organizations big and small, and individuals working to address local needs, we bring training and education to bear on your efforts. We're here to help you help others through evidence-based support, all at no cost to you. For instance, the Opioid Response Network helped the Tribal College in New Mexico join forces with local organizations to develop a culturally appropriate prevention, treatment, and recovery training series for its students. In Rhode Island, we convened correction staff from 34 states to share how our program had reduced post-incarceration overdose deaths by more than 60% and supported them in their efforts to build similar programs in their home states. In West Virginia, we mobilized to help a clinic incorporate substance use disorder services into their practice, serving a faith-based community. We helped healthcare providers in South Dakota address barriers they face providing treatment services for their patients. We're here to help those on the front lines. So, what are your needs and how can we help? Visit the opioidresponsenetwork.org to learn more and to submit a request for support. The Opioid Response Network, funded by the Substance Abuse and Mental Health Services Administration.
Awesome, thank you. Thanks, Maya. So there you go. That kind of gives a brief overview of kind of what the Opioid Response Network is and does. I posted the URL in the chat. The nice thing about this facility of the Opioid Response Network is that it provides free technical assistance to anybody around the country. So if you have a technical assistance need, you want to know how to implement motivational interviewing or CBT or continuous management for opioid or stimulant use disorders, you can get technical assistance for free. So this is kind of good news, courtesy of federal dollars through SAMHSA and the Opioid Response Network. So make use of that or share that with others who you think could use it. With no further ado, I will introduce our speaker. Oh, we're going to do a poll, right? Next, Maya?
Yeah, we
Before
have
Yeah,
a quick poll for audience members. I will go
Yeah.
ahead and launch that now. There are 3 questions in this poll, so make sure you scroll down to see all the questions. They're all
Yeah.
in one poll. And we will just wait a minute or so to make sure we have about 70 to 80% participation, but yeah.
thanks everybody for doing that. Just wait another 30 seconds for you all to do that. How are we doing there, Maya?
Good, yeah, we are about at 85% participation, so I can go ahead and end the poll and share the results.
Okay, fantastic.
Great, okay.
I love the instant gratification we get with these poll results. There we go. So this gives us a clue, kind of what people are doing on the webinar today, kind of what their roles are, and very cool. Fantastic. Thanks so much, everybody, for doing that. It's helpful for us to have, as well as you all to know. So with no further ado, for real this time, I'm going to introduce our incredible speaker that we're lucky to have today, Dr. Lauren Hoffman. And I'm happy to say that I have the privilege of working with Lauren and have had been a colleague of hers for actually several years. Dr. Hoffman is a research scientist at the Recovery Research Institute within the Center for Addiction Medicine at the Massachusetts General Hospital. She's also a member of the faculty within the Department of Psychiatry at Harvard Medical School. She's really been a pioneer in recovery research as it pertains to opioid use disorder. And she's looked at this from many different angles, including looking at the effect of medication use on neurocognition, which is a study, a NIDA-funded study that she's currently pursuing. And she's just been funded to do a fabulous new study looking at linkage to recovery community centers. So it'll be a randomized controlled trial to look to see if we can link patients with opioid use disorder on medications to recovery community centers and look at the engagement rates, utilization rates, and benefits derived from participation in recovery community centers for people with opioid use disorder. So that's a really exciting new study that Dr. Hoffman's been funded to do now. And we're looking forward, I'll be working with Lauren on that, I'm happy to say, and we'll be pursuing that, and we'll have some results in the next, hopefully the next couple of years. So over to you, Lauren. Thanks so much. And by the way, if you have questions, put them in the chat and we'll get to them at the end. Hopefully we'll have 10 to 15 minutes at the end to answer any questions that you have and have some time for discussion. Okay, thanks so much. And over to you, Lauren.
Thanks, John. All right, let's see. Is everyone seeing that? Good. Okay, awesome. Go ahead and start this. So I really appreciate it. I'm excited to be here and appreciative for John having me. So we're just going to jump right into it. Today we're going to be talking about Opioid use disorder through the lens of recovery research. So I'm going to start out by briefly reviewing some statistics. Then we'll discuss some findings from opioid use disorder recovery research recently conducted at the Recovery Research Institute. And then we'll finish up by talking about how these findings and the broader emerging literature in this area can inform the facilitation of treatment and recovery in practice. So we all know that opioids pose a major public health issue. In the US, there are over 9 million Americans that have misused opioids in the past year, and about 2.7 million meet criteria for a past year opioid use disorder. We also know that rates of treatment seeking are somewhat low in this population. So only about 11% of those with the past year opioid use disorder are receiving one of the FDA approved medication treatments for it. But 2.7 million, it's a large number, right? But opioid use disorder isn't the most prevalent substance use disorder. Alcohol is. So the question is, why is all this emphasis on opioids in recent years? Part of that has to do with the rapid rate at which opioid use disorder prevalence has increased in the last decade. And then the other driving factor here, of course, is overdose, something we hear quite a bit about these days. So there are about 207 opioid overdose deaths per day. And between 2017 and 2018, we saw deaths decline for most opioid-based substances, except for synthetic opioids like fentanyl, which you're seeing in this graph here. And those rates have continued to increase. There's also the huge economic burden, of course, of opioid use disorder. So prescription opioid misuse alone costs the US $78.5 billion per year. And so the opioid epidemic, it's often viewed, right, through this lens of overdose and fatality, but we also know that there's a lot to be learned from shifting our focus to the more optimistic side of opioid use disorders. And in this case, I'm talking about recovery. So if we shift our focus towards recovery, it can really give us a fresh perspective on addressing the opioid epidemic. So what do we know about recovery? So obtaining a prevalence estimate when it comes to recovery is somewhat difficult because we don't have a single cohesive definition of recovery per se. Notably, these national estimates are not opioid use disorder specific because substance specific measures are a little more difficult to find. But these broader estimates suggest that about 5 to 15% of the US population are in full remission, meaning that they don't meet DSM criteria for a substance use disorder within the past year, and about 50% or half of those with a lifetime substance use disorder achieve remission. The National Survey on Drug Use and Health recently started looking at perceived recovery as well, and those data suggest that about 73% of adults with a lifetime substance use problem report being in recovery or recovered. So importantly, though, these numbers speak to remission in those with a formal diagnosis, as well as to those identifying with the term recovery, which we know the definition can vary. And importantly, individuals who have resolved a problem with a substance but don't necessarily meet criteria for a formal diagnosis, as well as those who don't necessarily identify with the term recovery, are often left out of these estimates. And we also need, of course, substance-specific estimates to enhance our understanding of addiction and recovery. And this brings us to the National Recovery Study. So much of the data that I'm going to be discussing today stems from this study, which is a nationally representative survey conducted at the Recovery Research Institute and led by its director, Dr. John Kelly. And this study was designed to estimate national recovery prevalence using a nationally representative probability-based sample of individuals who self-report that they once had a problem with alcohol or other drugs, but no longer do. And so this is incorporating a more inclusive population of folks in recovery and allows for substance-specific prevalence estimates as well. And with this population, the study aimed to uncover and discover more about chosen recovery pathways and their correlates. Okay, so I'm not going to spend too much time reviewing the methods. In general, though, the study consisted of a sample of 2002 participants who self-identified as having resolved a significant alcohol or other drug problem. And these data were collected in 2016 and were weighted to accurately reflect the US population. And so in the first paper that came out of this study, we asked what is the prevalence of alcohol or other drug problem resolution. And we found that about 22.35 million Americans have resolved a significant alcohol or other drug problem. This is the breakdown by primary substance among those who reported a problem and reported a primary substance. So consistent with what we know about substance use disorder prevalence, alcohol is most prevalent here, shown in blue, followed by stimulants, cannabis, and then opioids. But this is a talk about opioid use disorder. So what have we found with respect to this population specifically? So in another assessment of the National Recovery Study data, we honed in on this opioid problem resolution group, and we asked what is the prevalence of individuals who have resolved a significant problem with opioids. We also asked what are their pathways to recovery. So for ease of communication, you're going to hear me refer to problem resolution as recovery because it rolls off the tongue a little better, but know that this is actually reflecting problem resolution in the context of the National Recovery Study. And so we looked at those pathways or service use, and we also looked at their psychological well-being. And we found that about 1.2 million US adults have resolved a primary opioid problem. So although there's an emphasis on opioids right now due to the magnitude of the opioid and overdose epidemic, we know that we know the most about recovery in the context of alcohol. So to put this prevalence estimate into context, there are about 11.4 million US adults who have resolved a primary alcohol problem. And because most of what we know about recovery is in the context of alcohol, given its prevalence, we compared these two groups of individuals who've resolved an opioid or an alcohol problem. And we examined these differences with respect to two recovery durations. So we looked at differences between these groups among those who were in early recovery. So here that was defined as the first year of recovery, and among those who had midterm recovery, meaning 1 to 5 years since they had resolved their problem, their primary substance problem. So how do their pathways to recovery compare? So looking first here at lifetime use of treatment and recovery services, we saw no differences between the opioid and alcohol groups in early recovery. But in mid-recovery, the opioid group had significantly higher rates of lifetime service use, and that's relative to the alcohol group. And this was seen for all services. So this includes medication treatment, recovery support services, mutual help organizations, and formal treatment services such as inpatient, residential, or outpatient treatment. So in interpreting this, it may be that individuals with opioid problems require additional services or more intensive service use than what is typically prescribed for alcohol use disorder to achieve these longer term recovery durations. Now, what about ongoing or current service use? And similarly, see, is this going to work? Okay, similarly, a greater portion of the opioid group were engaged in ongoing medication treatment. But again, this was only seen for the mid-recovery folks. So ongoing use of medication treatments beyond 1 year. They may also be needed for certain folks to promote longer term recovery durations from opioid problems. We also found that within both the early and mid-recovery cohorts that the opioid group had a higher prevalence of folks who were currently attending NA, right? Not surprising, Narcotics Anonymous. But there was actually no difference between the groups with respect to Alcoholics Anonymous attendance. And that was seen for both recovery durations. So that could reflect, potentially NA's reduced availability relative to AA in a given region, or maybe even the stigma surrounding opioid use disorder medication treatment in the context of NA meetings, which could encourage those in recovery from opioid problems to attend AA meetings just as much as those in recovery from alcohol problems. And that's because some report AA to be more accepting of medication treatment than NA, but really this is just speculation here. Okay, when we looked at psychological well-being, we actually found something interesting. So in early recovery, the opioid group had higher self-esteem than the alcohol group. But in mid-recovery, we saw the opposite pattern. And of course, we need longitudinal studies to confirm this, but we can speculate here a little that maybe the chronically relapsing nature of opioid use disorder and the need to return to treatment and engage in greater service use to achieve longer-term recovery, maybe that partially contributes to a reduction in self-esteem over the course of one's recovery journey. And that would regardless, call for enhanced support of individuals in longer term recovery from opioid problems to address deficient self-esteem and enhance well-being. Now, the good news is that none of the other well-being measures differed between the alcohol and opioid groups in earlier mid-recovery. So psychiatric comorbidities, psychological distress, happiness, and employment were all generally similar between these groups, regardless of the recovery duration. Okay, so with respect to the chronically relapsing nature of opioid use disorder, our teams also examined the number of recovery attempts that it takes someone to successfully resolve an alcohol or other drug problem. And although these results didn't reach statistical significance, likely due to the large amount of variability within each group that you're seeing, you can see that there were visually apparent differences in the distribution of the number of recovery attempts by primary substance. So if you look at the opioid group in the center there, you can see that the number of attempts may be somewhat higher in the opioid group, or at least more variable, emphasizing the heterogeneity of the disorder and the need for individualized approaches to treatment and recovery. Using these same data, we've also investigated one's level of comfort with disclosing their status to someone else as a person who has resolved a significant drug or alcohol problem. And overall, across all substances, my colleagues have found that being in recovery for a longer period of time was associated with greater comfort disclosing their recovery status, and that these individuals generally reported greater comfort disclosing to people that were closer to them, right? In social circles closer to them. So more comfort disclosing to family and friends, less comfort disclosing to coworkers, first-time acquaintances, or the media, for example. But these effects they varied by primary substance. So with those who had an opioid problem, they had significantly less disclosure comfort than those who had problems with alcohol and other drugs. And this is important, right? It ties into stigma and shame, and these can facilitate risk of relapse or return to use. So addressing disclosure comfort with, for example, more formal coaching on how to go about this might be helpful for patients with opioid use disorder. And certainly addressing stigma in healthcare systems and society at large could help to combat this. Okay, so I spoke a bit on recovery identity at the start of the presentation and noted that someone who's identified as resolving an alcohol or drug problem may not necessarily identify with being in, quote, recovery. So in this next paper, Dr. Kelly and colleagues looked at this exact issue. And they found that about 45% of individuals self-identified as currently being in recovery. There were about 60% that ever identified currently or in the past with that term. And They also found that a greater severity of substance use histories was associated with greater odds of taking on this identity or this label either now or in the past. And the proportion of those who'd resolved a problem and identified
you almost broke yourself.
and identified as being in recovery versus not was generally similar across substances. And when the opioid cohort was compared to the alcohol group in regression analyses, they didn't differ. Now, these analyses didn't focus on primary substance comparisons, so we likely need to assess this a little further to better inform the terms that we use as they pertain to recovery identity in different groups. But you can see that these numbers, they're reflecting that the majority of those who've resolved an opioid problem identify now or in the past with being, quote, in recovery. But there's still 1 in 4 of this group that don't identify with this label. So it's important to be sure that we're using appropriate labels for individuals based on what they specifically identify with. Okay, so let's return for a moment to well-being. And this time we're gonna take a look at measures of quality of life, which was the focus of this next paper that examined changes in quality of life as a function of time in recovery. So in this study, our team found a relatively rapid accrual of recovery capital. So recovery capital, these are the internal and external resources that are available for someone to initiate and maintain the recovery. And they include things like basic needs such as stable housing, family who support recovery, cultural or faith-based resources, right? As well as peer support. So we found a relatively rapid accrual of recovery capital here, as well as various measures of well-being that you can see during the early years after they've resolved a problem with their primary substance. And that was followed by a continued but somewhat attenuated accrual over time. And the one line that you see there on the downward trajectory, that's psychological distress, which means it's going in the right direction. So improvements occur pretty rapidly, right, in the first 5 years. But we also know that these things may get worse before they get better. Change isn't always linear. So for example, here in the graph on the right, you're seeing improvements in self-esteem and happiness, but they decline before they get better. So the orange line and the green line going down there, you can see that they decline and then they start to improve at around 6 to 12 months. So despite these improvements that we're seeing, it's really important to note that it takes around 15 years for individuals in recovery to achieve quality of life at the level of the general population. And 15 years is too long, right? Now, this may be due historically to the acute treatment paradigm with a focus on acute care and a lack of emphasis on what comes next, like relapse prevention, recovery capital, the removal of barriers that prevent individuals from rebuilding their lives, and a shift towards a recovery management model of care may help to reduce some of these barriers to increase one's chances at successful long-term recovery. Okay, so focusing on the opioid group now, how do these individuals fare with respect to individuals in recovery from other substances? It looks like recovery capital trajectories are the most stark difference between the opioid group and the other substance groups. So here you can see that the opioid group had significantly lower recovery capital compared to the cannabis and alcohol groups immediately following problem resolution. The other drug group, so that other line that you're seeing that starts out lower as well. And the other drug group primarily consists of, I believe, individuals with stimulant use disorder, but it's really anything other than opioids, cannabis, or alcohol. And they showed that same deficit. So that's why you're seeing 2 lines there and not 1. But both of these groups achieved recovery capital levels that were comparable to the alcohol and cannabis groups at around 3 years of recovery. So these folks are starting at a deficit and they're taking much longer to look like the other substance groups. And this really calls for an emphasis on the accrual of recovery capital and helping folks to facilitate the accrual of resources that they need to support their recovery. And we'll come back to some of the emerging research that's started to address these imbalances. All right, we've seen a lot of data here, so I'm going to briefly review for everyone some take-home messages here. So we learned that there are 1.2 million Americans who have resolved a significant problem with opioids. So we know people can recover, and a large number of them as well. What can we learn from them? We've learned that they may have needed to use additional or more intensive as well as maybe ongoing treatment and recovery services to achieve longer term recovery, that perhaps we need to offer individuals greater support and sustained recovery to boost their self-esteem. And other aspects of well-being, at least the ones assessed here, appear to be similar to those who are in recovery from other substance use problems. We also saw a high variability in the number of serious quit attempts or serious attempts to achieve recovery. And this emphasizes the heterogeneity of the disorder and the pathways to recovery from opioid use problems. We also saw less comfort disclosing their status as someone who's resolved a substance use problem, and this calls for additional support of patients with opioid use disorder to combat stigma. And this is because studies show that, decisions not to disclose can lead to enacted stigma, and that disclosing offers closeness in relationships and greater social support, which will then support their recovery. We also saw that many, but not all individuals who've resolved an opioid problem identify as being in recovery, with about 1 in 4, 25%, never taking on this label. And these individuals have a deficient quality of life for the first 15 years of recovery relative to the general population, as well as deficient recovery capital for the first 3 years of recovery relative to those with alcohol and cannabis use disorders or use problems. Which demands greater support to enhance recovery resources and well-being in early and long-term recovery. So we see some challenges, right, faced by these individuals in recovery, and some that are unique to individuals with opioid use problems. And so the question really is, with this knowledge, how can we facilitate recovery from opioid use problems at multiple stages of treatment and recovery? And when we're talking about substance use disorders in general, we know that at pre-contemplative and contemplative stages of change, so this is when individuals are either not aware of their problem or they're just starting to become aware of their addiction and maybe considering change, we can offer things like brief screening, intervention, and referral to treatment, as well as harm reduction services like emergency services like naloxone, which offer the opportunity to reduce individual harms. And then at the preparation and action stages, and when someone's committed to making a change, we can offer clinical interventions like intensive outpatient treatment, medication treatment, as well as psychosocial therapies. And we can also offer non-clinical interventions too. So these are things like mutual help meetings, such as NA, and community recovery support services, such as recovery community centers. And at the maintenance stage, so this is when individuals are maintaining their recovery, they're successfully avoiding a return to substance misuse. We can offer things like continuing care in the first year of recovery. So this is, for example, recovery management, recovery checkups by phone or text message, ongoing engagement in clinical and non-clinical interventions as well, such as ongoing pharmacotherapy or mutual help participation. And then after the first year, we can also offer recovery monitoring, such as less intensive checkups, maybe they're not so frequent, ongoing psychosocial therapy, and sometimes even ongoing engagement in non-clinical or clinical interventions, right, depending on someone's individual needs. So clearly, patients need more than just acute short-term treatment. And thankfully, it's becoming more widely accepted that we need recovery-oriented systems of care and ongoing recovery management to achieve and maintain recovery. This image comes from NIDA, or the National Institute on Drug Abuse, who now endorses offering a wide range of services that someone might need to achieve recovery. And this doesn't just include acute stabilization. It also includes things like recovery support services, addressing physical health like HIV or hepatitis C, as well as, for example, educational and vocational services that help people regain a functioning life in which they're thriving and hopeful about the future. And we'll review the science on a few of these services that can be offered at various stages of change. So starting with clinical interventions at the action stage of change, medication treatment, It's now considered the gold standard for opioid use disorder treatment. And there's been an increase in the availability and use of all three medication treatments for opioid use disorder over the last several years. And these include agonists like methadone and buprenorphine, which you may know as, for example, by the brand name Suboxone, as well as antagonists or opioid blocking medications like extended release injectable naltrexone, also known as Vivitrol. Okay, so despite these increasing trends and the proven efficacy of these medications, though, there's a persistent unmet need for them, So you'll recall that I had mentioned that there's only about 11% of individuals with opioid use disorder who receive pharmacotherapy. And so the question is, why do we have this ongoing unmet need? And research has identified several barriers to medication receipt. This includes institutional, provider, policy, and financial barriers. So helping patients get access to these medications is one way to facilitate their treatment and recovery. There are also, though, barriers at the individual level. So, for example, attitudes towards opioid use disorder medication treatments. And this includes the attitudes of the recovery community as well. And these attitudes are important because personal attitudes towards these medications and attitudes among recovering peers can also influence a person's treatment and recovery pathway. So, for example, studies show that negative attitudes towards a given medication can deter patients from choosing that treatment, and positive attitudes are associated with better treatment retention. So this area of research is growing, and thus far would lead us to believe that medication attitudes are predominantly negative in the recovery community, particularly for agonist medications. And this is because some have misinterpreted these treatments as replacing one addiction for another, which we now know is not the case. But thus far, these reports generally suggest that between about 20 to 50% of recovering individuals in these various populations have positive attitudes. So in general, negative attitudes could be more prevalent or just as prevalent as positive attitudes in these samples. Okay. So you'll recall treatment shouldn't end at medication, and engagement in recovery support services is one way to promote treatment retention and ongoing recovery. But here's the issue, right? So if recovery support services are typically run by recovering peers, and they've shown in these prior studies to potentially have negative attitudes towards medication treatment, how do we marry these two seemingly clashing supports for patients? And recovery community centers may be one answer to this problem. So these centers are free, peer-led one-stop shops for recovery support services. They offer anything from social recreational activities to mutual help groups, recovery coaching, employment and education assistance. And these are all services that individuals can engage in at any stage of change, right? From early treatment to longer term recovery. And so recovery community centers have the potential to be a promising venue to support individuals who are engaging in medication treatment without potentially compromising their treatment or their well-being. And this is because we know that these centers are especially inclusive. They don't follow any particular recovery model, and they operate under the maxim that there are many pathways to recovery and all of them should be celebrated. At least in the New England region, the United States, our team has revealed that recovery community centers are visited most often by individuals with a primary opioid problem. So here showing that about 41% of recovery community center attendees report opioids as their primary substance, and that's shown in red here. So to give you an idea of just how prevalent opioid use disorder is at these centers, the figure on the right shows the prevalence of primary substance use problems from the National Recovery Study, which shows that 5% of the general recovering population has a primary opioid problem versus 41% at recovery community centers on the left there. And this emphasizes that this is generally the minority in the general recovery population, but the majority at recovery community centers. So the inclusive nature of these centers and high prevalence of members who have a history of opioid use problems could then potentially offer an environment, right, that's supportive and accepting of individuals with who are using medications for opioid use disorder. So we wanted to know about medication or attitudes towards opioid use disorder medications in the context of these centers. And to get at this question, we investigated medication attitudes or attitudes towards these opioid use disorder medications among recovery community center attendees. And so these data stem from a cross-sectional survey of 336 recovering adults who attended one of 31 centers in the New England region. And about half the sample you can see here in orange and gray in this pie chart, about half the sample was in their first year of recovery. So as part of this survey, participants were presented with 4 statements regarding 4 different medication treatments. The first 2 concerned opioid use disorder medication treatments, and the bottom 2 there concern alcohol use disorder and mood disorder medications, and those were included for comparison. And all statements communicated that it is a good idea for someone with an opioid, alcohol, or emotional problem to take a medication to help them with that problem. And for opioid medications, you can see we have 2 there. So we individually addressed agonists, so things like Suboxone or methadone, and then antagonists like naltrexone or Vivitrol. And so participants indicated their level of agreement with each of these statements on a 1 to 6 Likert scale, and responses were dichotomized. So any level of agreement was categorized as a positive attitude, and any level of disagreement was categorized as a negative attitude. And we found primarily positive attitudes towards opioid use disorder medication treatments at recovery community centers. So for all medications, you can see that positive attitudes shown in blue here were more prevalent than negative attitudes. So what if we compared this to the general recovery population using the same survey items to provide a direct comparison? And so this is unpublished data looking at the same survey question in our national recovery study, and we see a 50-50 split in positive and negative attitudes. So side by side, there we go. We can see just how much more positive these attitudes are towards agonists and antagonist medications in recovery community center members relative to the general recovery population. So these centers and their culture, they clearly hold potential for truly welcoming and equally supporting and advocating for those who use medication treatments along their recovery journey. And they may be a good option as a recovery support that doesn't clash with the idea of medication treatment to really ensure comprehensive approaches to treatment and recovery. So while we're on the topic of these recovery community centers, our team has also looked at their potential benefits to those who attend them. And again, remember, the majority of recovery community center attendees have a primary opioid problem. And so In this study, we found that more frequent attendance in the past 90 days at a recovery community center, as well as a longer history of attendance, was associated with enhanced recovery capital, right? Those resources for recovery. And if you recall, we found in the National Recovery Study that recovery capital is more deficient in individuals recovering from an opioid problem during the first 3 years of recovery. So, right, a potential avenue for addressing these deficits. And we also found that greater recovery capital was associated with lower psychological distress, higher self-esteem, and higher quality of life. And again, you'll recall in the National Recovery Study, we saw deficient self-esteem among individuals with 1 to 5 years of recovery from opioid problems. So these centers have massive potential to address some of the unique difficulties that these individuals might face when seeking recovery from opioid use problems. All right, so we've talked a bit about recovery community centers, but there are definitely several other services with benefits to individuals seeking recovery from opioid problems. So for example, in a study conducted at MGH, our colleagues have evaluated recovery coaches. And so if you don't know, recovery coaches are peers in recovery who are trained to motivate patients, provide support to help address barriers to care, behavioral change. They also help patients navigate treatment and recovery systems and locate and access harm reduction services. And of course, they offer social support. And this study found that 6 months after patients engaged with a recovery coach, there was a 44% decrease in patient hospitalizations and a 9% decrease in emergency department visits. There was also a 66% increase in outpatient service use, so patients reliably showing up to their appointments. And among those patients who initiated buprenorphine, they found that those who were currently in contact with a recovery coach, they had 89% increased odds or likelihood of engaging actively in their buprenorphine treatment, and 32% greater odds of being abstinent from opioids at that time. So recovery coaches also appear to be a potential great benefit to treatment and recovery. Mutual health organizations like NA, AA, Smart Recovery, these are also shown to benefit individuals at various stages of recovery. And so in one study conducted by Weiss and colleagues, they looked at service use among individuals with prescription opioid use disorder and found that opioid agonist treatment, right, so buprenorphine or methadone treatment, and mutual help group participation each independently increase the likelihood of abstinence in these patients. So for example, individuals participating in mutual help organizations at 42 months of follow-up were about 2 times more likely to be abstinent at that time. You can see that here. Mutual help participation shown in green. And these were additive independent benefits of mutual help groups and medication treatment, meaning that the benefits seen for one didn't necessarily detract from the benefits seen for another. And similar outcomes have been seen in previous research looking at other types of opioids like heroin. So for example, in this other study, among individuals who attended residential treatment for a heroin problem, abstinence from opioids increased over a 5-year follow-up period, but the clients who attended NA or AA after treatment were more likely to be abstinent from opioids at follow-up, and that's at all of these follow-up periods here across various years. So social support is clearly another domain of recovery capital that seems to enhance recovery outcomes for those with opioid use disorder, particularly social support from those with lived experience. Okay, and these are just a few of the recovery support services and mechanisms we can use to promote recovery, right? So there are a ton I didn't discuss here today just for the sake of time. For example, post-overdose outreach teams in the emergency department have been shown to enhance treatment engagement, retention, and overdose prevention. Peer outreach workers in recovery have also shown to help connect individuals to medication treatments for opioid use disorder. and get them initiated and started on those treatments. And individual therapy or contingency management during medication treatment for opioid use disorder has also been shown to promote abstinence and prevent overdose. And I'm sure that we'll learn much more as this scientific literature continues to grow, and we'll know what works for whom. Okay, so what did we see here today? Overall, 1.18 million Americans have resolved a significant opioid problem. This is a decent number of individuals, so we know that recovery from opioid use problems is possible. We also know that opioids may require additional or more intensive, these individuals may require additional or more intensive services to achieve longer term recovery. And that those with greater than 1 year of recovery may need enhanced support to address deficient well-being or more specifically self-esteem. The number of recovery attempts may be somewhat more variable for those who have resolved an opioid problem, and that suggests or emphasizes the heterogeneity of the disorder. And we also know that they face some issues, right? So individuals who've resolved an opioid problem have the least amount of comfort disclosing their recovery status. They have deficient recovery capital in the first year of their recovery. And so these things really need to be addressed. And we also know that there are about 1 out of 4 who never identify as being, quote, in recovery, but there are a large number of individuals who do identify with this label. And nonetheless, we should be paying attention to using labels that others prefer that we use when we specifically speak with them. Okay, but knowing this and knowing all the obstacles that these individuals might face, we've also learned that there are ways to support them. We can facilitate recovery with a combination of clinical treatment, non-clinical recovery support services, continuing care and recovery monitoring. And this means using evidence-based treatments, right? Like medication treatment and enhancing access to these medications by reducing barriers, as well as finding ways to retain patients in treatment for maximal benefit. It also means using recovery support services, continuing care, and recovery monitoring to complement treatment and promote recovery success. So for example, we saw that recovery community centers may be particularly beneficial for individuals to address these deficits in recovery capital and self-esteem. And they may also be a welcoming, great environment for those who are receiving medication treatments. Recovery coaches also seem to benefit individuals as well. And of course, mutual help organizations, tried and true, seem to benefit not only in the short term, but also the long term. So the theme that we should take away from here today is that we learned that there's a lot to be learned from recovery research to guide treatment and recovery, because by understanding what's worked for those with lived experience, right, of addiction, treatment, and recovery, we can better help facilitate the recovery trajectories of future generations. So with that, I'd like to thank, of course, all of my colleagues at the Recovery Research Institute, this great team of people, many of whom contributed to the research that you saw here today. And of course, Dr. John Kelly, our fearless director. And of course, also want to mention the Recovery Research Institute website, if I have time to do so. So at this website, you can sign up for our monthly recovery bulletin. It synthesizes the most up-to-date recovery research in a digestible format for the public. I highly recommend you sign up. It's completely free. All you have to do is go to recoveryanswers.org, and then you enter your information in the lower bar down there where it says sign up. And we promise there's no spam. There's just a once monthly recovery bulletin that you'll get in your inbox. And yeah, with that, I'll take any comments or questions that you might have.
Well, Lauren, thank you. That was absolutely fantastic. What a tour de force review from epidemiology right down to the nuts and bolts of recovery and the temporal topography of change and relative to other substance use disorders, and really highlighting the tougher challenge it looks like what we're discovering is the tougher challenge that people with opioid use disorder, particularly heroin use disorder, are having in recovery. You know, just how long it takes them to catch up to their counterparts in terms of recovery capital and quality of life in those early years, and how these recovery support services like recovery community centers can play such a vital role and seem to be, at least in the New England area and New York State, a vital role for providing access to support, as you said, advocacy and support to help folks who have opioid use disorder, who are taking medications, to be supportive in that. And you showed very nicely connecting the dots of some of these data points, which I think is very critical for us all to understand, is how these things can be, you know, the picture that is being painted by these data points. You nicely connected those in terms of helping us understand exactly how these resources can be utilized to the benefit of individuals with opioid use disorder, using recovery community centers, for example, to boost their self-esteem, recovery capital, quality of life, and functioning. That's really hopeful. So it's a really nice emphasis and change to look at opioid use disorder, as you said right at the beginning, through the lens of recovery. We do know that most people with opioid use disorder do achieve recovery. And so that's the question is, how do they do that? How can we help these individuals who seem to be more marginalized and stigmatized more quickly and more readily? So we have lots of requests for the slides. You will all get the slides. Those of you who are here on the call, feel free to share those with colleagues. We'll have this recording as well for you all to view in the future on our archive website at Recovery Answers, so you can view it anytime. Maya, do we have questions?
Yes, we do have some questions in the chat. One of the first ones that came in is from Daniela Rodriguez, and they asked, does Recovery Community Center equal rehab center? Are 12-step meetings included?
That's a great question. So no, they're not the same thing. So they are not a rehabilitation center. What they really are is a local place where people can go freely and willingly to engage with others who are in recovery. It's sort of like, if you've ever heard of the term clubhouse, that's kind of where these sort of originally emerged from, where these clubhouses, the idea that you have this local source within your community that you can go and visit. And they'll offer, some of them do offer recovery support groups and meetings, 12-step meetings as well, some of them, but they are very different from rehabilitation centers, if I'm thinking of them in the way that you are. It's a good question.
Great. Okay. And then we have another question that asks, how are recovery community centers typically funded?
That's a great question. I think it depends. Isn't that right, John, on where like the states that they're in and the way that they function? Many of them, some of them are funded by the communities themselves. I don't know. Are there ones that are funded by the state, John?
Yeah, exactly right. It's highly variable. At least that's what we found out so far in this preliminary study that we've done in New England and New York State. We're going to find out a lot more because we're conducting right now a national study to look at how these things are funded. So we're going to learn more in the next few months, actually. We've gotten a lot of that data collected. But for example, in Massachusetts, we have about, coming up for 40 centers. They're all funded through the Department of Public Health, for example, through state-funded entities. It depends on where you are. In Vermont, that's not the case, so it's less the case. In different states, it varies.
Great. Okay. And then another question we have from Nina Christie. They asked, is there a comparison of recovery coaches for opioids and alcohol? Are they more effective for one group over another?
I am not personally aware of any study that is specifically comparing the efficacy of one for one group over another. I think more than anything, though, those who are lacking in resources and social support, regardless of the substance that they're using, could benefit from these great resources of recovery coaching. So anyone who needs that social support, the guidance and accessing the resources they need. If anyone doesn't have, for example, if you don't have stable housing, then you really need to find stable housing to better facilitate your recovery, and a recovery coach might be able to help guide you in a direction that is both good for your recovery and good for you as an individual. But I'm not aware off the top of my head of any that have compared alcohol to opioid. And I think it really is, regardless of substance, that it's beneficial for anyone who can benefit from enhanced resources, recovery capital, social support, even just helping to keep people engaged in their treatment.
Well, we're right at 1 o'clock right now. So I know people will have to go. So we may hang around for a few more minutes. If you have questions, we could chat for a bit longer, but just to formally end it, I think we should do that so people who have to go can go.
Can I mention one thing, John, beforehand? The poll that we did, we should never be doing medically managed withdrawal without any type of follow-up treatment. So that was the one in there that wasn't meant to be selected for anyone who did select it, is the general guidance these days.
Thanks, Lauren, for mentioning that.
Sure.
And thanks everybody for coming. Delighted to have you. Please join us again next time. You'll get emails regarding the next, which is coming up in a couple of months, I think, Maya, right?
Yes, June 22nd will be the next presentation.
June 22nd, so look out for that. Thank you. Thanks for all the great comments, great support, great questions. And we'll stick around for those who want to stick around for a few more minutes, and Dr. Hoffman can answer some more questions. But thanks, everybody. Have a good rest of the day. Thanks for joining us all. So, yeah, do you want to just ask another couple of questions there, Maya? I think there were a couple.
Yes, absolutely. We have one question. Let me see if I can get it again. That was asking to comment on how recovery community centers might look in rural communities.
I'm not entirely sure. So I'm actually relatively new to this recovery community center world of research. I know that Dr. Kelly's research has looked at, in the New England region thus far, and then his national study will probably reveal more. I'm not exactly sure what I imagine they're all a little different, but I'm not entirely sure.
Well, I think it's kind of the general challenges of rural populations being less dense, having a lower quorum of people available to be able to support the centers, peers in recovery that live nearby that can participate in the centers. So all of these challenges make it more difficult for people to have access to these things. Obviously, if they're in rural areas, to travel to an area where there is greater population density, where it may be a more robust enterprise with more people, can be challenging, because we do know that the time it takes to get to these places is a significant predictor of utilization. In fact, in studies that we've done already, we found that to be actually one of the most important was how long it took to get there to the centers, was correlated with how frequently people attended. This has been replicated in clinical studies as well, in terms of how long it takes for people to get to their clinical appointments. So accessibility, in other words, is a really key factor in utilization. So it makes it more challenging for rural populations. Of course, with COVID, what's happened with these online resources is now a lot of these facilities have been able to be implemented online, which means access to some degree. It's not the same, is it? This as opposed to the peer support live and in person, up close and personal and visible in those settings. But it is something that is a definite lifeline for people to have this access through online, these virtual platforms is great. It's good news. Yeah, those challenges remain in rural areas. Also, there's greater visibility, which means it's harder to be anonymous, to have confidential access, because you're more visible in rural areas. It's not so easy to hide, as it were. And so you're more visible, you stand out in a smaller population, and that can be harder for people, therefore, to access. There's no doubt about it. They feel stigma themselves. There is public stigma around these things still. We're working on that, of course, all the time, but that makes it also more challenging because those folks are more visible in those less dense populated communities.
Will we know from your study coming out what percentage of recovery community centers are located in rural communities?
We will do. Yep.
Oh, that's great.
Yep. One more question?
Yep. Okay. So another question is, what is the difference between a recovery coach and a sponsor?
So when I think sponsor, I think 12-step, I think NA, AA, right? So this is typically an individual within a mutual help group that helps guide an individual somewhat informally. With a recovery coach, you can find these coaches in medical settings even. So you might find them in recovery community centers, you might find them in a medical facility, and they are typically certified in what they do. So they undergo certification to become a recovery coach and to be able to provide that support and linkage to resources in someone's community. And a sponsor is more, even though they are also somebody who is in recovery themselves and has lived experience, typically they aren't necessarily trained, right, formally to be somebody that supports someone's recovery journey.
Great. Cool. All right. Well, it's time to say goodbye. And thanks for hanging on for these extra questions. Really great to see everybody. Please keep coming back and join us again next time in June. I look forward to seeing you then. Please reach out to us. If you have questions for Dr. Hoffman, please reach out to her directly. I'm sure she'll be happy to answer questions, supply any of the papers that she cited in her talk today. Thanks, Dr. Hoffman, again, for just a fantastic overview. That was really inspiring to see, and it gives us a lot of food for thought and avenues to pursue in this area of research, because there's so much to do here with this population and understanding how people achieve recovery and remission. So you've really opened the door and connected a lot of the dots for us today. So thanks for doing that.
Thank you. I appreciate
everybody.
you having me here.
Thank you,
Thanks,
everyone.
everybody.
Maya, are you gonna have, I didn't look at any of the questions or comments on here. Is there a way to get a transcript just to make sure that no one reached out with a question that I didn't respond to, or did they request anything?
Yes, I can download. I'll download the chat right after this and email it to you. One question that was DM'd to me that we didn't get to was where is this? Where did this go? About the cost of recovery coaches.
Okay. It's also variable. It's hard to answer. They're sometimes free. All right, awesome.
But yeah, I will download the chat and email that to you, as well as some other data as we get to them. But thank you so much. This was fantastic. I really appreciate it.
Yeah, no worries.
Awesome. Yeah.
Yeah, let me know if you need anything else. And I think I sent you the slides for you to post, and we should be good to go.
Awesome. Yep, we are all set. Thank you so much.
Bye.